Let's start. Good morning, everyone. Today I am here to present my seminar on the topic of seasonal affective disorder and updated review. And my moderator is Dr. Shobit Garg, sir. This is an overview of the under which we will study the topic of seasonal affective disorder. First of all, we will study about introduction, then epidemiology, then place in diagnostic system, etiology and pathophysiology, clinical features, investigations, treatment, course and prognosis. Seasonal affective disorder, also known as seasonal depressive disorder, is a mood disorder which commonly occurs in areas that experience low sunlight level and which occurs in the same season every year, usually in the late fall and winters. Significant changes in the amount of sunlight alters the concentration of essential hormones like serotonin and melatonin, which play an important role in the circadian rhythm, and which leads to seasonal affective disorder. Directly associated with seasonal affective disorder is directly associated with elevated levels of the melatonin. Involvement of neurotransmitters like dopamine, norepinephrine, and glutamate has also been hypothesized by various studies. Epidemiology. According to physical locations, areas experiencing the four seasons are most likely to get affected because of fluctuations in light are more common at such places. Higher altitudes are more affected than the lower altitudes, and Sweden experiences a significant seasonal affective disorder prevalence, commonly termed winter depression. Sweden has close to 8% of the cases. Prevalence is more common in young adult females than the young adult male. Changes in circadian rhythms and hormonal concentration seems to have little to no effect on seasonal affective disorder prevalence among the elderly. History of depression is patients with history of depression are more likely to contract seasonal affective disorder. Seasonal affective disorder peaks during winter season when sunlight levels are at their lowest level. During spring, the depression suddenly lifts off and an individual returns to normal. Diagnosis. Seasonal affective disorder is diagnosed as a major depressive disorder, bipolar 1 or bipolar 2 disorder with the specifier with seasonal pattern in the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders. The seasonal pattern specifier criteria include this specifier applies to the lifetime pattern of mood episode. The essential feature is a regular seasonal pattern of at least one type of episode, that is mania, hypomania, or depression. The other types of episode may not follow this pattern. For example, an individual may have seasonal manias, but his or her depression do not regularly occur at a specific time of the year. Criteria 1 is there has been a regular temporal relationship between the onset of manic, hypomanic, or major depressive episodes and a particular time of a year, example in the fall or winter, in bipolar 1 or bipolar 2 disorder. Such cases do not include in which there is an obvious effect of seasonally related psychosocial stressors, example, regularly being unemployed every winter. Number 2 criteria is full remissions or a change from major depression to mania or hypomania or vice versa also occurs at a characteristic time of the year. Example, depression disappears in the spring. In the last 2 years, the individual's manic, hypomanic, or major depressive episode have demonstrated a temporal seasonal relationship as defined above, and no non-seasonal episodes of that polarity have occurred during the 2-year period. Number 4 criteria is seasonal mania, hypomania, or depressions as described above substantially outnumber any non-seasonal manias, hypomania, or depression that may have occurred over the individual's lifetime. Etiology and pathophysiology. The condition has linked to effect on neurotransmitter availability, sensitivity, and regulation, which affects the circadian rhythms. Evidence for a circadian phase shift associated with serotonergic hypothesis. Theories describing pathophysiology of seasonal affective disorder are mainly concerned with circadian rhythm dysregulation, neurotransmitters, genetic polymorphisms, hormones, and other physiological factors. Serotonin hormone has greatest effect due to its association with circadian rhythms. fatigue, and sleep induction. Serotonin is lowest in the human brain during the winter season. Phase shift hypothesis proposes a direct connection between the circadian rhythm and sleep-wake cycles. Endogenous circadian rhythm is known to shift during winter when days length decrease and the duration of exposure and amount of light is low, affecting sleep wave cycles. The resultant phase delays are proposed as the major cause of mood swings during the leading to seasonal affective disorder. Serotonin hypothesis, association between seasonal affective disorder and presynaptic serotonin transporter has been hypothesized by various studies. Monoamine hypothesis of depression, in which there is increased uptake of serotonin by the presynaptic neuron, is dependent on binding the transporter. The surge results in an elevation of depressive symptoms. SAD has also been linked to genetic inheritance. The serotonin 2A receptor gene is closely linked to gene variation, seasonality, depending on the season. The receptor gene is highly sensitive and reactive to fluctuations in season and affects normal individual physiology. Risk factors are younger age, female gender, family background, presence of other depressive disorders, and living far away from the equator. Clinical features. Initially, SAD patients do not exhibit anhedonia, low mood, or other typical symptoms, but rather present with as a diagnostic tool for SAD. Research reveals a significant association between seasonal pattern assessment questionnaire results and visual impairments, which is based on SAD parameters, potentially indicating that a decrease in retinal light increases the pathogenesis of the SAD. These parameters are therefore used as diagnostic and therapeutic tools. Management. Following are the main treatment used for seasonal affective disorder. First of all, treating intrinsic medical condition. Second, light therapy. Third is hormonal therapy. Fourth is use of antidepressants and dietary modifications. Increased exercises, meditation, sleep hygiene, tone stimulation, ECT therapy, and vitamin D. One of the major treatment is cognitive behavioral therapy, generally once a week. Antidepressants and light therapies can accompany such treatment. Other therapies include an increase in physical activities and exercise to boost dopamine elevation. Exposure to light can also be used for the regulation of melatonin and serotonin. Therefore, most individuals suffering from SAD are often advised to move to warmer places at the onset of winter and fall to prevent the above conditions. Whenever there are recurring symptoms over time, the same therapies and protocols can be used more consistently to become more effective. Social behaviors such as drug abuse, isolation, and stress should be avoided. Light therapy at any time of day or night aids in reducing depressive symptoms and advancing circadian rhythm. The primary form of light in light therapy is blue light, which is of moderate frequency and normally found in the morning sunlight. Light therapy. The standard protocol for light therapy for depression uses white light at an intensity of 10,000 lux for 30 minutes per day during the early morning for up to 6 weeks. Light therapy is usually well tolerated with few or mild side effects. Although the precise mechanism of action of light therapy remains unclear, it is hypothesized that alteration in the circadian rhythm, suppression of melatonin secretion, and modulation of serotonin may be an important contributory factor. More recently, it was shown that melanopsin, a photopigment located in the retinal glial cells, modulate the circadian effects of the light. Melanopsin is particularly sensitive to wavelengths of light in blue color range, that is 450 to 480 nanometers, And low intensity blue light can shift circadian rhythms as effectively as higher intensity white light. In addition, melanopsin plays an important role in suppressing melatonin production, as well as improving alertness and neurobehavioral performance, which may mediate some of the antidepressant effects of the light. Increasing evidence suggests that it is also effective in light therapy is also effective in non-seasonal major depressive disorder and bipolar depression also. Bright light therapy has been proven to be effective for patients of all ages, and it is also effective with depressive episodes associated with pregnancy and childbirth. Course and prognosis. A wide range of therapies such as antidepressant, light therapy, CBT, vitamin D are used in the treatment of SAD. Almost 70% of individuals have recurrent symptoms of this seasonal affective disorder. In order to manage the condition and reduce SAD symptoms, early diagnosis, therapy, and community education are essential. In handling an extreme seasonal affective disorder case, such as hypomania, close monitoring of SAD patients is especially crucial. Depending on its intensity, chronic SAD can have a chronic or disabling cause. In order to prevent recurrence of the symptom, during the brief window of change, patients are encouraged to continue their medications as prescribed, and the recurrence of symptoms could be worse than the initial. These are my references.
I think floor is open for questions.
Yes, ma'am. Because ma'am, it has been hypothesized that seasonal affective disorder, in seasonal affective disorders, melatonin, serotonin plays an important role in the circadian rhythm. And during winter season, due to decreased sunlight, melatonin levels increase in the body, which makes the person more lethargic, relaxed, which lead to these symptoms like lack of concentration and low mood.
Good answer. So melatonin we should not give this. Someone coming to us with seasonal affective disorder. As per presentation,
Yes, sir, we should avoid.
So this context patient comes with seasonal affective disorder, complaining of insomnia.
Yes,
So shall we give melatonin or not?
sir, we should avoid.
Melatonin. Any side effects of melatonin?
Currently, there have not
No side effects. Sure. Any cutaneous side effects? What do you consider seasonal affective disorder? More a part of depression or bipolar or something else? Your comments.
Sir, more of a part of the depression.
But DSM is a specifier.
Yes,
So DSM considers that it can be present with any of the
hypotension.
population. Is seasonal depression an indicator of bipolarity? Everyone, patients will definitely come to us with winter onset. So many patients will come with depression, sudden onset depression. So are they indicators of bipolarity? Should we think about
Yes, sir, sir. But we have to take brief history और नॉन सीजनल एपिसोड्स सीजनल एपिसोड्स के नंबर्स क्या है सर सीजनल एपिसोड्स के नंबर नॉन सीजनल एपिसोड्स को आउट नंबर करते हैं देन वी कैन कंसीडर एज सीजनल
you said DSM 5 about ICD 10 and 11 where
sir they have specified seasonal affective disorder under the heading of recurrent depressive disorder in both ICD-10 and ICD-11.
So for ICD-10 and 11 does not consider if manic episodes are occurring in a particular season, so there is no place to mark these disorders.
No, sir. Sir, they have mentioned mania under seasonal manic episodes.
Yes.
Yes.
Where?
Sir, sir is asking about
seasonal mania.
yes.
Yes,
Yes, sir.
In our context, light therapy is not.
Yes.
Generally, so how you will treat those patients there? Or a patient with winter onset depression, time lock, the holy IEG, then they'll be separate.
So first of all, I will psychoeducate the patient. And then, sir, I will try to give him low dose antidepressant. Then I will ask the patient to sit more in sunlight, more sunlight exposure, vitamin D supplementation.
So early morning, sunlight exposure. Yes. So generally in winters in Delhi specifically because of fog, there is actually no sunlight exposure. Yes. Maybe till 2 p.m. something. Yes. That context it becomes very difficult to manage. Any questions? Very important. And what do you mean by Z zappers? Internal Z zappers, external Z zappers? Any idea?
The spaceship hypothesis is directly related to in winters, duration of daytime decreases and nighttime increases, which leads to disturbance in our circadian rhythm due to change in melatonin level, which directly disturbs our sleep-wake cycles.
She asked, is delay and phase advance? You mean by what phase is delayed? What phase is advanced? And
Yes. Yes. And not.
phase delay is advanced.
Test phase advance.
Huh?
Test phase जो सर evening time advance हो जाता है.
होता क्या है? Phase that delay is happening. What happens actually? Person will sleep very late and get up very late. So the sleep time and waking times are delayed. Advances, they sleep early and will get up. Jet lag attacks. And in night duty workers, so somebody is sleeping very early and getting up very early. So his phase is advanced. And in delay, it has delayed. So and most of the adolescent population post-COVID, they're suffering from phase delay. Basically, the second thing that you use light stimulation. So it will reduce a lot of patients on the complaint that the child is sleeping at 12, 1, 2, and then they keep up sleeping till 12. So later, the stimulation would reduce the melatonin, and then subsequent melatonin surge will happen. It will either suppress or it will happen in the later part. So they'll get up at 1 o'clock, 2 o'clock. So in that context, but how do you manage those? It's very challenging. How you manage this? तो मान लो कि 1 बजे दोपहर को उठता है तो आप उसको फिर आप क्या बोलोगे अगर उनसे भी 3 बजे सोते हैं आपको मोबाइल भी देखना बंद करो 3 बजे सो रहे उठता है 1 बजे gradually shifting how gradually every day. How you have to tell the patient, na? Mother will said in 5 days, she will ask him to wake up at 6 o'clock and become very groggy and loud.
So once a week.
Once weekly timings of the period करनी है, preferably बाहर. You can stretch it to there are various protocols and you can time those this to melatonin supplements. Very early part of the evening. They are saying even give melatonin at 3 p.m., 4 p.m., 5 p.m. and subsequently predate those so that जो फेज डिले है वो सेटल और दे आर डिफरेंट प्रोटोकॉल. किसी को स्टैंडर्डाइज्ड वो नहीं है. मेनी यूनिवर्सिटीज हैव डिजाइन्ड देयर ओन प्रोटोकॉल्स
and shift like in that like this, 4 hour shift was one cycle. So if you are going for acute, then 4 hours. The other, then say the abrupt this thing is that you set up a wake up time. You wake up at that time, irrespective of this. Don't wake up for, don't sleep for half an hour, and then it will gradually. It is difficult, but for let's say cold turkey is like kind of a thing. It is very difficult. You change somebody's. If somebody set it for like weeks or months, then it is very difficult.
Generally, the jet lag they automatically resolve by the time variations are basically resolved in few weeks, few days will become there. Generally, 5, 7 to 10 days it will settle in that. It becomes a disorder when it doesn't get settled. Any other question? So winters में आपका see here in this context. We are saying is sunlight exposure to melatonin substance and which results in disturbance of these diet variations and possibly depression. This is what happens. But आप देखेंगे कि what happens classically when your nights gets very longer, आपकी 6 p.m. in Indian context, 6 p.m. 7 p.m. sunlight goes off. So generally people would sleep earlier than they get up early. Or they'll have very diluted sleep, non-restorative sleep, non-refreshing sleep, because the sleep times are important to sleep more is increased, and brain would acquire those limited sleeping time, and then gradually we adjust to either delay or advance both can.
In countries like Iceland,
Right. And sir, we can ask the patient to move to some warmer places and can also
Immigration.
So we can, sir, in other countries are light therapies available, so we can offer them.
We are talking about treatment in the context of any chemical disorder, depression, or sleep.
The side effects will be like
the point is if someone in any country there is 3 months of summer and 9 months of winters, and in 9 months patient has history of seasonal depression, which we diagnose it from past history, then you have to give patient some light therapy, maybe for initial few weeks. Patient will tend to improve and subsequently take it out. That would be the best. I suppose because we are not at first and experience of treating these kind of patients because of the different context here and non-available country. So we only depend upon it. So what we here advise is we sit in front of the rising sunlight so that they have early exposure. Maybe, but this is not evidence-based. It's not written anywhere. This is just a more light exposure. But problem is in places like Delhi where there is actually no sun exposure.
Some seasonal fluctuations will also be less, right?
Yeah.
As she has mentioned, 8 to 9 months के लिए winter yeah, तो सर seasonal fluctuations की भी hypothesis है उसके कि सर अगर जहाँ पे ज़्यादा seasonal fluctuations होगी वहाँ पे ज़्यादा seasonal affective disorder के chances.
What do you mean the seasonal fluctuations? The
change in seasons, sir, summer, spring, late fall, winter.
okay. Talking longer, they say in the context of the long winter, and people adapt.
Just like
But for somebody coming there, it will be a problem for maybe to be 1 or 2 years. With insomnia, that a private detective comes to that place and they're very long days for insomnia, like you just can't sleep. Because it's like they're working in summer and there is light all the time. Even in places in Europe, like London. In winters, it is dark at 4, and in summers at 8, 9 also it is bright. There also somebody going from here, find it very peculiar, like at 8 o'clock, 9 o'clock, you are still having light, sunlight. But people, they that. But someone has a personal experience here, little like this. So it's very difficult for us to understand. No, but see, I've been in Calcutta. In Calcutta, the whole daytime is where at like 8, 9, it is very bright light because in India we have one standard time. But ideally, I think if you follow the astronomy, then in the eastern part of India, there should be half an hour, 1 hour time ahead of us. Like, now Bangladesh is half hour ahead of us. That is there. Like there, the timing is different. Although we don't feel it because we are following the same clock, but if somebody comes up used to this far, so you have a greater fluctuation daytime. There at I think at like sunrise is early, 5, 6. That's good. So comments. Now German impact. You don't need to any guideline. Like European journal, Indian journal.
Patients, and especially in the networks sense, they are unable information to this.
And then subsequently, what's the problem?
Yes, so especially during the summer and this like they are able to take patient.
Pathway. So again, that is what fibers subsequently going to wear. Really, really interesting. Something to do with some cervical part of the spinal cord. Huh? Yes, very good. Rosenthal. Yes. Huh?